بسم الله الرحمن الرحيم. الحمد لله رب العالمين. الحمد لله الذي هدانا لهذا وما كنا لنهتدي لولا أن هدانا الله. اللهم صل وسلم وزد وبارك على سيدنا محمد حضرة النبي الأمي وعلى آله وصحبه وسلم. عذرا سأقول مقدمة بسيطة جدا جدا، وأعتذر لأخي العزيز الغالي أستاذ الدكتور هيثم الجميل، لكني لن أذكره محددا، ولكني سأقول سلاما سلاما للذين لم تتحول غربتهم إلى اغتراب وقسوة، بل أينعت غربتهم سنابل قمح وأعواد ريحان. سلام للذين يمطروننا بغيثهم من العلم وكريم الأخلاق. سلام للذين يشتاقون لبهية والنهر وشط اسكندرية والنخيل وزهر الرمان. سلام للذين يستيقظون فجرا يشتمون رائحة زهر الليمون والبرتقال ويعشقون الوطن ومولعون بنيلهم الأسمر. سلام لكم جميعا. شكرا. تفضل يا دكتور ياسر.
بسم الله الرحمن الرحيم. Dr. Haytham, your camera not working. Can you open it?
I'll just a moment. Camera, okay. Okay, stop share, stop record, start video. Okay, now I'm starting the video. Now you can see me now, hopefully.
I can see you, but I don't see the share. It's okay. Can you open again? Yes, okay. Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the army behind this fascinating work by the lead of Prof. Safa Hilal, Prof. Anesthesia, Minnesota University, for this invitation as a moderator. With my colleague and my friend, Dr. Haytham Algameel. Our speaker today, for this, from his name, Algameel, it is the name and the character. It means the beautiful for the people not speaking Arabic, and he is. Thank you, Dr. Beautiful, for giving us this time and effort. Dr. Gameel is a consultant of cardiothoracic anesthesia and ICU in Aberdeen University, United Kingdom, a former assistant professor of anesthesia and a consultant of cardiothoracic anesthesia at King Fahd University Hospital, Saudi Arabia. Our speaker today has a great depth of experience in his field of anesthesia and ICU. His clinical and educational activity well known in our anesthesia community, as he has an arsenal of education activity online and local. And not only because the speaker is beautiful, also the topic is very beautiful today. You know, this topic will be on depth update about musculoskeletal and anesthesia. And you know, the third pillar of anesthesia is muscle relaxation, and we'll need to know a lot about this muscle and pathology which are affecting relaxation and affecting anesthesia. So I am very interested to listen to the topic of neuromuscular disease and anesthesia, and I think you are. It is the time for takeoff, and I will give the lead for Dr. Haytham, the beautiful. Thank you, Dr. Haytham. Can start.
Thank you so much, Dr. Yasser. Definitely, Dr. Safa, thank you so much for your really very nice, organized introduction. You handed over really for Dr. Yasser, who resistantly actually managed to say a gush of wonderful words, a fascinating introduction, actually. I try to gather myself after that really nice words, and hopefully I will be able to be deserved with that kind of really very nice greetings and regards. Thank you so much, everybody, and I'm really very honored actually to be with you, ladies and gentlemen, with this very nice and interesting presentation. Not because actually I'm the one who's organized the presentation, but because actually it's been encouraged by your presence, and with the generating this kind of activities being generated by Dr. Safa and Dr. Yasser. I will crack on with the topic, which is mainly focusing on one of the most irritating, let me say, irritating disease that we are facing it really on regular basis in our anesthetic management. And to be honest, I am I'm just trying to move with the slide. Okay, so first of all, I'm really declaring that there is no conflict of interest about any of the other products that have been mentioned here in the in my presentation, whether it's a drug or whether it's a tool or equipment. And cracking on with the why we consider that kind of management. Actually, it's very critical and challenging for all of our colleagues all over the world, not only in our theaters, even in the Middle East or even in the Western world, because actually it carries a lot of threats for our anesthetics management. And the term of threats could be affecting our hearts, arrhythmias, or even the myocardial functions, or maybe to the lungs in the form of prolonged ventilation, or maybe the risk of aspiration, and definitely the prolonged recovery of the neuromuscular functions afterward. Here, just to speak about the neuromuscular junction in brief, and to be honest, I'm not really going in depth with the physiology, because I know it's really a bit irritating as well. But simply, if you have an action potential that creates a calcium release that causes the acetylcholine to cross the neuromuscular junction and bind to the receptors on the other side, and that's what creates the muscle contraction at the end. This is simply how it works with the neuromuscular junction. Here, when we have a pathology, those kind of pathology might affect either pre-junctional or in the area between the junction and the post-junctional area as well. For instance, the lower motor neuron lesion, the multiple sclerosis, Guillain-Barré, and peripheral neuropathy in the form of the diabetes or ataxia affects the pre-junctional zone, and the junctional mainly carries the pathology of that might affect the myasthenia gravis and the Eaton-Lambert disease or the myasthenic syndromes, and post-junctional mainly takes the dystrophies, the Duchenne, Baker's, myopathy, inflammatory or myotonias in general, and hyper and hypo periodic calcium paralysis as well, or potassium paralysis. So each side of the neuromuscular junction affected in a way or another by that. But let's have a look here to the myasthenia gravis, and it's an autoimmune destruction of the postsynaptic acetylcholine receptors. And we have a kind of antibodies that those antibodies actually work against the receptors and decrease the number of the receptors. So whenever the acetylcholine particles or molecules cross the neuromuscular junction and try to bind with the receptors on other sides, have limited number of the receptors, and that's what causes the disease of the myasthenia gravis. That's as simple as we told. So that's what causes the myasthenia gravis, are involved as well with the bulbar involvement, laryngeal or pharyngeal weakness, cause some sort of difficulty in the swallowing, and definitely might cause problems in clearing the copious secretions, and finally it might end with a pulmonary aspiration. So those are the main risks, along with the muscle weakness and the easy fatigability. And one of the main characteristic symptoms here, those symptoms are as always worsen with exercises and improved with the rest. In other words, if he creates more exercises, they have more weakness, and if he gets resting, so probably that's what may stay still for a long time, that might make the symptoms improving. I'm talking about the bulbar involvement, laryngeal, pharyngeal, and the problem, even the problem related to the lung as well. Going to another type compared to the myasthenia gravis is the Eaton-Lambert syndrome, and simply there is a failure in the presynaptic calcium entry, and normally those calcium, as we mentioned before, stimulate the release of the acetylcholine. Simply, you can differentiate that the muscle weakness improves with exercise. So when you attain more exercise, this weakness improves. You get more strength with that, and it's been treated also with some of the drugs that might really help even increase the calcium influx as well, and be considered with the main thing that it might really improve the weakness, or helps to treat that weakness. In the case of the a muscular dystrophy in the form of the Duchenne muscular dystrophy, and everybody knows that it's X-linked recessive disorder, mainly in males, and affects the patient, produce abnormal dystrophin protein that precipitates in the sarcolemma of the muscle fibers and cause some sort of a fatty infiltration. So there is progressive proximal muscle weakness. Proximal means mainly in the upper extremities, and this might also associated with the gait disturbances, and it has a fatty infiltration of the muscles, and it becomes like a Popeye's, Popeye the Sailor Man. I mean, Popeye's hand as well. However, those muscular dystrophy also might involve the respiratory muscle weakness, cause the respiratory muscle weakness, and presented by the atelectasis and also restrictive lung disease, and associated with impaired cough and higher possibility to develop aspiration as well, inability to clear the secretion, and might even goes more further to affect the papillary muscles, causing a muscular dysfunction in the heart presented by the cardiomyopathy and mitral regurg due to the rupture of the papillary muscles inside the heart. Simply, those even much goes more. This muscle injury goes even beyond than the gross or the gross pathology to affect the bloods in the form of having a higher serum creatine kinase, high serum myoglobin, and the main thing here, just to diagnose the liability to develop that, has been very obvious whenever you do a muscle biopsy. So this is a very routinely used to diagnose this kind of dystrophy. Myotonias is something different and caused by the mutation of gene of chromosome 7q35, doesn't matter. Encoding the calcium channel, the skeletal muscle fibers at the surface membrane. And this disease actually is being confined only in the skeletal muscle. So it hardly affects the other types of muscle, even the cardiac muscle as well. However, it might be associated with some trismus, high liability to develop trismus in the mandibular muscles. It might also have some sort of high liability to develop arrhythmias, but however, it could be no or minimal or non-progressive, but it might affect the heart as well. I will just try to compare on the treatment. So myasthenia gravis, definitely everybody knows. All the myasthenic patients usually get most of the available drugs, which is in the form of the acetylcholinesterase inhibitors, and those improve the acetylcholine availability in the neuromuscular junction and carry the risk as well to have the cholinergic crisis, especially with the excessive doses, and might cause weakness, which could be differentiated from the muscarinic crisis by the use of the hydrophonium tests to differentiate between the cholinergic and muscarinic crisis. And definitely we know that muscarinic, this is a very famous MCQ question, the muscarinic crisis worsen with the hydrophonium, and then the other way around with the cholinergic crisis. With the Duchenne muscular dystrophies, might really needs the corticoids and for long-term treatment with the corticoids and the spinal roading or fusion, and improve the mobility and having more comfort as well. And even other types in the form of the plasmapheresis as well could be used with the treatment of the Duchenne muscular dystrophy. Again, the associated risks is not so far from what we said before. The high risk of the postoperative ventilation and respiratory failure, which is very common with those patients, as well as cardiac troubles in the form of the cardiomyopathies, valvular involvement, and having mitral regurg, and arrhythmias as well. Muscle weakness, which might cause inability to clear out the secretions and high liability to develop regurg and aspiration. And finally, the malignant hyperthermia, which is one of the great risks and threats in our anesthetic practice. Here, let me start first to talk about the possibility to develop a malignant hyperthermia. And just simply, you can figure out that if the patient is very liable to develop this kind of malignant hyperthermia by the family history.
Look, Haytham, your sound and picture is frozen.
And you can check also the type of the weakness and the extent. You can see that, Dr. Yasser?
It's okay now. It's okay.
It's okay. You can see it now.
Yeah. Yes, okay.
Okay, sorry. And moreover, the muscle group as well that been involved and the extent of the weakness. Here, as well as the other associated risks that might really affect the types of one of the types of the neuromuscular disease, like especially the myopathies. When we have a patient who have a cardiomyopathy, so whenever you feel that this patient having a possibility to develop a cardiomyopathy, you should know that he might really have valvular involvements, and that what makes the patient actually more liable to develop systemic or pulmonary hypertension, and high liability also as well to develop arrhythmias. And this might need the cardiological intervention or a cardiological input just to make sure that you are very clear with the diagnosis as well. Well, now we're going to the choices now. What type of choices are you going to use? We have definitely the major territories of anesthetics, either go to the regional anesthetics or GA. And whenever we talk about GA, we have a possibility to go with the TIVA or using the neuromuscular blockers or additional agents if you want. The type of the procedure and duration will be the judge of that, actually. And I would say that mainly we can go simply with the regional anesthetics, because if you can manage to manage those patients with the regional anesthetics, definitely that will carry more susceptibility of the management, may be more safe for the patient. But in case of you've been put in the corner, I mean, you've been trapped in the corner, just we need to go with a procedure that it might be a little bit longer than we expect, or the procedure actually requires the need for GA. That actually makes you in the position that you need to take a choice, either go with the TIVA, going to the neuromuscular blocker, or maybe using inhalation as well. So here I'm trying to go with the slide. Okay, so simply, let me go. I'll go back. Okay. Oh, so simply, the choice here. Sorry, I have a little bit slow in moving with the slide. Okay. Okay, so that actually makes the famous question: shall we go with the muscle relaxant or not? Okay, the effect of the muscle relaxants here are differs. Can you see the slides, Dr. Yasser?
Yes, we can see it.
Yeah. Well, the effect of the neuromuscular blocker, and this table actually showed the effect of the neuromuscular blockers on the impact of the disease on the neuromuscular blocker. And simply, if you can check the depolarizing muscle relaxant like succinylcholine compared to the non-depolarizing muscle relaxant neuromuscular blockers, we can see simply that the depolarizing muscle relaxant have a resistant effect of developing a phase 2 block or unpredicted response in the myasthenia. In the Eaton-Lambert have a sensitivity, and it might precipitate a severe spasm and trismus, and definitely everybody knows that it might really cause malignant hyperthermia and severe hyperkalemia with Duchenne myopathy. On the other hand, non-depolarizing have a sensitivity in all the types of the neuromuscular, with the exception of the myotonia, which might cause spasmodic response, which might be unpredicted. The acetylcholine esterases definitely has been used for the treatment of the myasthenia, so the patient might have a resistance with the effect of the varidostigmine or the neostigmine in the case of the myasthenia, and might really have a spasm or trismus in the myotonia. The volatiles, it could provide you with a good intubating conditions in the myasthenia, but definitely it should be contraindicated with the Duchenne myopathy, and could be safe in the myotonia, and it provides a good intubating condition as well in the Eaton-Lambert. Benzodiazepines and opioids could be sensitive whenever being used for myasthenia and Eaton-Lambert, and be prolonged with effect with the Duchenne myopathy, and will be prolonged as well in the myotonia. Here, the effect of the acetylcholinesterases, which is very obvious actually with developing the spasm and trismus with the myotonias, and it's been used and resistant in the field of, never been used in the myasthenia. So it's not in the button, actually. It's you can press the button and just check whatever you like. So still we have to choose between the Tiva and the remifentanil propofol, which have been used as choices in the Tiva, and use a rocuronium, a combination of a steroidal non-neuromuscular blocker along with the reversal of the sogammadex, or maybe muscle relaxant with a reversal. And it's all about how you can choose the right choice and keep your patient safe. Let's talk first about the TCI remifentanil, or using the Tiva, using the TCI or a target controlled infusion with the remifentanil, which might provide an adequate relaxation. And it's been really published in the European Journal of Anesthetics, and it shows a very nice response with the total intravenous anesthetics, especially with the propofol and remifentanil, especially when used for a video-assisted thoracoscopic thymectomy in patient with myasthenia gravis. Here, when we have to choose between taking the patient to the theater and you need actually to conduct general anesthetics and you make sure that the patient is not really spontaneously breathing at all. So in the case of the video-assisted thoracoscopies, the VATS surgery, to do the thymectomy, the patient should be totally flaccid. And then you need actually to give general anesthetics, and you need the patient to be fully relaxed. So when they use the remifentanil TCI along with the propofol, it gives a very good intubating and surgical condition as well. As simple as that. But here in the myasthenia gravis, do you know this picture for whom it belongs? This is, by the way, the senior. The senior people, like us, maybe knows him. He's Onassis. Onassis is one of the billionaires in the 60s, and he married to Jacqueline Kennedy. And Jacqueline Kennedy is the ex-wife of the President JFK, or John F. Kennedy, who was being assassinated in Texas. Why she married him? Maybe because of his money. I don't care about that. But the main thing is he is really a myasthenic patient. He can live a normal life. So my message here, that the myasthenic patient could be easily treated as a normal patient. And especially if he's being controlled. If he's being controlled with a myasthenic treatment, probably he can receive even short-acting neuromuscular blockers along with a new stigmine reversal. It might be slightly resistant, but at the end, it will do the job simply. And it goes, it provides the adequate relaxation that you are really looking for, provided that you can manage to monitor this reversal by the effect of by the use of neuromuscular transmission monitors. Here as well, remifentanil could be used along with the dextror as well for the myopathy. And here, a myopathic patient who received anesthetics with both dexmedetomidine or the Brisidex, or whatever being called. So I prefer to call it the dexmedetomidine at the induction dose of 1 microgram. It's been maintenance dose as well with the 0.5 to 1 microgram per kg per hour, along with the remifentanil 0.2, 0.4, and it gives really a marvelous response. And you can check that as effective. Dexmedetomidine considered as an effective agent and can be used as an alternative for inhaled or other intravenous anesthetic techniques. So this is one of the other choices as well. It can be used simply along with the midazolam for induction, and it gives really a very good intubating and very good maintenance condition as well. But the main thing here, if you want really to start, a procedure when the full and deep muscle paralysis is being required, like for instance in laparoscopic surgery or abdominal surgery, or whenever you need to maintain thoracic surgery for using the 1-1 ventilation, putting a double lumen tube, maintaining ventilation throughout the procedure. You don't want the patient to have a paradoxical respiration, or in the cardiac surgery for a long time, for instance. Then that makes really the use of muscle relaxant is really mandatory here. Here we come to the pivotal moment. We need to check if we should go with the conventional combination of the neostigmine for the reversal between the neostigmine and glycopyrrolate or any anticholinergic agent, or to go with the Bridion or what we call it the sugammadex. And according to many reports as well, the last one actually in 2019 in PMC and pathology, they mention and they highlight that the cardiac arrhythmia, especially with the patient who's been susceptible to develop those arrhythmias, like patients who is having a history of AF or VF or VTACs, like the myotonic patients, for instance, or maybe the myopathic patients, I might have really a very grumpy and very sensitive response to the use of the normal or the conventional combination of neostigmine and anticholinergic. That's what makes the Cochrane review emphasize on the need of the sugammadex as a faster, or more efficient, and even safer compared to the use of neostigmine in reversing the moderate or deep paralysis as well. So we are not talking only about the safety and the efficiency. We're talking all again about the possibility to use the anticholinergic agents that might really cause more arrhythmias. Here, we focus more on the need of those combinations as well when we discussed that in the current opinion of anesthesiology in 2016, and it showed that the 10 myasthenic patients who underwent a VATS and required a deep neuromuscular blockage using a 0.3 milligram per kg of rocuronium, which is really slightly lower. I mean, they're trying to lessen the dose. I mean, trying to limit the dose being required for the surgical procedure. And even the patient required more additional doses as well. And the whole procedure is being monitored by the use of TOF or train of 4 or neuromuscular transmission monitoring, NMT. And finally, they received the sugammadex of 2 milligram per kg immediately after the surgery. And the recovery of the TOF to obtain a 0.9 and above, I mean, or like 90% and above for twitches takes up to 90 seconds in all the subjects, okay? So this means that the sugammadex now is being used efficiently in those patients. However, not only in the myasthenic or the patient for thymectomy or the myopathic, but even in the Guillain-Barré as well. Here, the anesthetic technique is slightly maybe individualized with those patients according to the surgical and preoperative condition. But it seems that it works out with them, and there is the risk of actually having respiratory or residual neuromuscular blockage had been lessened or been avoided or been obtunded by the use of the rocuronium and the sugammadex. And by the way, sugammadex could be used with the vicuronium as well. So I'm not really advertising about rocuronium in specific. You can use rocuronium, you can use vicuronium, and you can really use the sugammadex for the reversal in those patients. Here also in the case of myotonia, it shows many reports in the European Journal of Anesthetics and in the anesthesia and intensive care as well, and shows the use of sugammadex for the reversal in the management of patients with a Baker's myotonia congenita or in patients with the myotonic dystrophy as well. The motor neuron disease, even whenever been used for the cases with a spinobulbar muscular dystrophy, like Kennedy's disease, those patients at high risk actually for developing a laryngospasm and the bulbar involvement as well in the form of the bulbar dysfunction and aspiration at the end. And definitely those patients as well are more liable to develop a very prolonged postoperative ventilation as well. The main thing here is also this combination is being used, and the same dose as well will be used. And to attain to achieve a count of 1 and 100% reversal, it's been taken up to 3 minutes, 180 seconds in patients with the Kennedy's disease. And those patients actually and commonly have been going to a very prolonged, horrendous post-operative involvement of most of the respiratory muscles and might really stays on the ventilator for a very, very long time. But the use of this combination definitely avoids those complications in those patients. here we should also, we're not talking about the magic drug. So some of the patient as well is having some delayed reversal with the sugammadex, and it might be because the high surgical stresses, or in the case of pregnancy. So whenever you deal with the patient, with the traumatic patient, for instance, a patient went to the ureter with the trauma, massive trauma, sepsis, septic patients, or those patients who have a severe responses after the cardiac arrest, for instance, patients with severe malignant hyperthermia as well, before the procedure, or the pregnant ladies as well, might be contributes to the delay of the return of the muscle power, and definitely what might cause some sort of resistance with the use of the sugammadex. However, despite the reversing with the sugammadex, 2% of those patients, one of the reports actually might found them need have a residual reversal, and the rate is less, the train of 4 is less than 0.9, and in the recovery room, and might needs an extra dose or additional dose of the sugammadex in order to reverse the TOF. And let me say the limit actually to make sure that your patient has been very well reserved, or at safe point, is to maintain the train of 4 above 90%. So those patients, let me say that we should consider like 2% of those patients who've been reversed, the patient with neuromuscular disorders might really requires a second dose of the sugammadex in order to reverse the effect.
Sugammadex.
Let me check. Oh, yeah. I need, there is, okay. Here, another question actually would jump, and pop into our mind. Actually, it's a very booming concern, and that was not really available before. That could we use the sugammadex in myopathic patients or myasthenic pediatrics? And this is really very, very interesting question, and a very, very, let me say, the very challenging as well, actually decision as well, because before it's not been really encouraged by the company, or by the sugammadex producers, just to use it in the children. But what if you have a patient with a neuromuscular disorder and he is really less than 12 years old? So probably we came to a very good report actually discussing the current evidence of the use of sugammadex in children in 2017 in the Pediatric Anesthesia journal, and it shows that the use of rocuronium and bicuronium could be achieved, in order to reverse the use of the rocuronium and bicuronium in those patients, especially in patients with having a myopathy, or having high susceptibility to develop myopathy or delayed recovery for any reason. And that's what actually the main indication of using the sugammadex, because it's at the end, it is really a very expensive drug. So, we have another combination can be used easily with those patients, like using the duodoximine and the anticholinergic as well. But whenever you've been deciding, and I know that many facilities actually limits the use of the sugammadex in a very particular situation, whenever a patient is having a myopathy or patient has been susceptible to develop the kind of delayed recovery. For those patients, actually, around 200 pediatric patients received the sugammadex, but they never managed actually to attain or to achieve the count 2 or the train of 4 of 67% and above, until they get the sugammadex dose of 2 or even up to 4, double the dose being required milligram per kg, and occasionally the second dose was required to achieve the 4 reversal with those patients. So this is another cause of the delays as well, because we should expect that not only the stresses, not only the surgical stresses, not only the complexity of the surgery, not only the pregnancy, but even the pediatric patients might really require a higher doses of sugammadex in order to achieve the reversal at the end. Delayed reversal, we mentioned that. But to avoid this delayed reversal with the sugammadex, which is it could be used as a good drug, but strongly recommended in many policies and many procedures to maintain the neuromuscular monitoring and ensure the complete recovery for the effect of this, especially for the steroidal and neuromuscular blockers like rocuronium and vicuronium. And even they emphasize on the need for this extended post-operative supervision of those patients in high dependency areas. The reason for that is to maintain the best outcome. What I mean by the best outcome is that we need to achieve a choice that it might really requires safe anesthetics to be conducted, efficient anesthetics as well, in the form of the proper choice. The titration of your doses is important as well, and the selection of the good reversal at the end. NMT monitoring is important, which should be maintained not only in the theater, but even in the recovery, or even when you took the patient to the high dependency area. The successful anesthetic management usually in those critical patients should be focused mainly on the rapid emergence of the anesthetics and rapid recovery of post-operative respiratory and protective functions as well. Appropriate hemodynamic monitoring will be guard against the cardiac congestion that might really be very common with cardiomyopathic patient or with the patient with the myopathy in general. Oh, this is, I'm skipping one of the slides here. Oh. Oh, there's, oh, sorry. There is one slide before the thank you, but anyway, thank you so much at the end.
Thank you, Dr. Haytham, for this informative presentation. In conclusion, you know that you speak about variability of neuromuscular disease. It is not one, and the response to anesthesia different from disease to disease, and even for muscle relaxation. And you show how what is the aesthetic management, the choice, and the management is not one fit all. And your conclusion about it is a very interesting for me, because you know usually you don't remember how to manage these people because it may be a rare case, but very important to know everything about it, because you may kill the patient if you don't know what is the pathophysiology behind that. And you know, and it is a very informative, and everyone is just touching this in his practice. Now, if anyone just wanted to ask Dr. Haytham about the presentation, he can put his question in the chat box. But before to go, I have one question for Dr. Haytham.
Yes.
Dr. Haytham, you speak about the different type of anesthesia. You speak about general anesthesia and regional anesthesia. Those patients with regional anesthesia, if you make a regional anesthesia for this patient, the response will differ from a normal patient. What I mean, the concentration of the drug, the time of the drug. And do you think that regional anesthesia may be a good choice or not in some area?
Yeah, that's a very nice question. Thank you so much, Mr. Dr. Yasser. Well, regional anesthetics usually might really have a negative impact also in some of the patients, especially when we talk about if you decide, for instance, to go with the high blocks, like giving spinal or epidural anesthetics in some of the patients with the limited respiratory reserves, it might really affect them. Definitely, that's what makes the general anesthetics is a valid choice on the table. So whenever you have a problem with the spinal anesthetics, for instance, or the higher spinal, or with the epidural anesthetics as well, definitely epidural is much better than those than the spinal anesthetics, because it's the onset is a little bit longer. Be taken, so there is no aggressive response on the heart, especially if the patient having a severe cardiomyopathy or a severe mitral regurg. But let me say that, especially with the patient with the severe mitral regurg for the cardiomyopathy, the spinal and regional anesthetics is really, it could be a very beneficial, because we should maintain, fast forward patient, but as long as they can maintain the hemodynamics using the appropriate doses of spinal anesthetics, not going with the higher doses, titrating your doses. That's what I said. Actually, titration is quite important. And if you use the appropriate technique, avoiding the higher levels, maybe that's what works with the patient. But the main actually challenges is whenever you try to start anesthetics with patient who's actually not appropriate to sleep or to lie flat for a long time, because we should consider as well that if the patient having cardiomyopathy for any reason, having lungs are being flooded for any reason, so he might be able, to sleep for a long time. So that's what makes the general anesthetic, as I mentioned, as a valid choice. But definitely the titration of the doses will be much more safer for your patient and for yourself as well.
Thank you, Dr. Haytham. But I just you answer about half my questions. The other question I don't read about it. The other question, for example, for peripheral regional anesthesia, for example, upper limb anesthesia or lower limb anesthesia. Do this patient respond differently from a normal patient? For example, he need different doses, concentration. Is a response for anesthesia can increase more than the other people or not?
They are very sensitive. Let's say that definitely with the myotonic patients, for instance, the effect of the general anesthetic, the effect of the spinal or regional anesthetics might really differs from the patient with the myopathy.
Yes.
That's what I'm saying. The doses could be, the doses should be lessened. Should be reduced compared to the normal patient. In the myotonic patients, especially with the patients with having any potential to develop trismus or to develop muscle spasms, that might really requires, local anesthetics infiltration for some particular areas as well. But in general, the need for the titration of the doses, because in the other hand, those higher doses and the effect of those local anesthetics on the in the neuromuscular junction or even in the sodium channels as well could be aggressive. It could be very high sensitivity, and that's what requires a less doses. So let's say from the other from the other perspective, that those patients, as long as they are requiring lesser neuromuscular blockers, definitely they will need a less local anesthetics, because the effects of the local anesthetics and the neuromuscular blocker definitely will be aggressive compared to the normal individuals.
Thank you, Dr. Haytham. I have a question from our colleague, Dr. Amri. He asked about if you consider the polio is one of the neuromuscular disease. He asked about the people who survive from polio disease, and some of this patient coming to anesthesia, do they respond differently to neuromuscular blocker or like the normal patient?
Well, very sensitive as well. It might those patients as well be. Let's speak about our ability to judge on those patients. Definitely, if you saw a patient and you know that this patient have a neuromuscular disorders, you will never be generous in giving muscle relaxants. To be honest, you try your best actually to avoid the higher doses. You will titrate your doses, and at the end, you want to make sure that this patient will never goes to the ward before a very close observation. In other words, you will ask for post-operative ventilation. My message here is that those patients definitely should never be treated as a normal individuals. In other words, that those patients should receive the titratable doses. And if you look even to the literature about the how people can deal with the polio, you found that there is no potential actually to gather a huge number of cases and a huge number of those individuals in order to come out with a Cochrane review or come out with a publication that actually covers 200 or 300 patients, for instance, because those patients, you found most of our informations about how we deal with a particular, apart from the polio, with the other neuromuscular diseases, it depends on the case reports and depends on the multicentric studies. So what I mean is those advices mainly focus on titrating the neuromuscular blockers and keeping your gun in the hand, like ability to use other choices in the form of propofol and remifentanil, TCI, TIVA, for instance, to avoid any delays in recovery. And at the same time, if you had to give the muscle relaxant, you should go with the possibility to use neostigmine and glycopyrrolate as anticholinergic, or even escalate that to use the sugammadex if needed. And at the end, monitor your patient in the recovery. And at the end, maybe the patient might really requires a post-operative ventilation as well.
Thank you, Dr. Haytham. I have another question also. I don't know that a question or comment, but he asking about Sugmadex can be used for a newborn or not?
No.
And any evidence about?
No. There's no evidence to use it in newborn at all. Actually, till 2017, were no reports, actually enough reports that actually supports the use of the Sugmadex even in pediatric. So it usually is being used in the adult above 16 years old, as long as the patient is having a more than 40 kg body weight, it can be used. But those reports came to the came to the view, or came to the screen, or came back to the scene starting from 2017, when more people are being encouraged, to go and involve the pediatrics, especially if there is an expectation of delay in the recovery. That's why, when you talk about the pediatrics, those pediatrics actually should be at least 5 years and above, but never in the newborn and infants as well. And I think there's some restriction as well if using the lower ages. In the lower age, if the patient actually is not really big enough, to receive a good dose of Sugmadex.
Thank you, Dr. Haytham. Really, we have many questions, and Dr. Samir Kafrao is my friend and my colleague. He asking about those patients need an pulmonary function test preoperatively or as a routine or not?
For the myopathic patient, it could be a good choice, yeah. But for the myasthenic patients, it's not really required at all. For the myotonia, it differs if the patient can come. Came to you with any respiratory involvement before. Like in the form of if any myotonia that might involve the respiratory muscles, or maybe have symptoms of having chest infections, prolonged chest infections, or maybe having any symptoms related to the bulbar involvement as well, might really reflect the bulbar involvement. But for the myopathic patient, the patient with the myopathy, with the Duchenne, with the Baker's, they might definitely need a pulmonary function test. But to be honest, it's easy. Those patients actually will not actually get benefit. We are also considering that those patients might really come in emergency. So we will not send your patient for an emergency, an urgent patient, or for doing an, let me say, having a fracture, orthopedic fracture, the trauma, or maybe having hernia, strangulated hernia. We would never ask him, about the pulmonary function test. But in case of you dealing with an elective patient and you have a time to send him for the pulmonary function test, definitely it's well and good, okay? But it might be really very beneficial as well, yeah? But we know from the beginning, as this patient having a restrictive lung disease. So, that might really confirm the diagnosis. But definitely we know that from the beginning.
Yes.
So please, Dr. Yasser, please, Dr. Yasser, I can summarize it. If the patient already have pre-operative pulmonary disease, obese patient, upper abdominal surgeries, all of that can influence the need for the pulmonary function test to demand it promptly. If I have upper abdominal big incision, if I'm obese, if I have pre-operative pulmonary disease, multifactorial.
Okay, I agree with you. Well, yeah, but what I mean is, as long as I know the type of the duration of the surgery as well. Let's say to have an abdominal operation or a thoracic operation, for instance. So if the patient is going for a thoracic surgery, probably I know from the beginning that patient might really require the pulmonary function test, because this is one of the main investigations that have been required for all the thoracic patients. But if you're expecting that the patient actually have an extension for the surgery for the abdominal, for instance, the patient would start with a laparoscopic and there is potential to convert to open laparotomy, then we need to check if the patient requires an ICU bed. We will go with the mid-flow and check if the patient having, but I know from the beginning actually that this patient might even go to the post-operative ITU or the HDU or high dependency in order for their ventilation as well. So pulmonary function test could be useful, but we should expect from the beginning that this patient having a restrictive lung disease anyway. So it might really might not have that kind of let me say, a marvelous response to our management. At the end, we will take the patient to the ITU.
Yes.
Excuse me. Excuse me. Excuse me. May I have a comment here, please?
Yeah.
دكتور أسامة اتفضل.
دكتورة صفاء ازي حضرتك؟
Professor, Doctor, excuse me, Dr. Yasser, Dr. Haytham, this is our great Professor Yasser Osama Hamdi. He is our colleague from Qina. From Qina.
Yeah, it is from Qina, yeah.
He's sharing us for the first time. For the first time. Welcome,
Dr. Osama is a star and my colleague, and he stayed with me many years in Cancer Institute.
Indeed, Yasser Bey. Indeed, Yasser Bey. Thank you for this very nice lecture, and thanks for your brave to go into this lecture, because most of us worry about myotonic and myopathic patients. Again, Dr. Safa, how if we check the pulmonary function, have a basic pulmonary function test, I can't see how it is going to help us managing our patient. I think it could be a delay for order pulmonary function test, and it's not going to have a great effect on our anesthetic management. As Dr. Yasser said, we assume this is the guy's having a problem, pulmonary function problem, and we go on with it. What do you think? I don't think it's advisable to ask for or to order pulmonary function tests routinely for myopathic patients. What do you think, Dr. Yasser?
You know that it's individualized from the case to case, as Dr. Haytham said. You know, if you have this patient, and as Dr. Safa said, if you have Duchenne myopathy and the patient obese and have a problem in the chest and have a time just to do that, it's okay, but it's an emergency. I think it will not add anything to delay the patient in emergency to make a pulmonary function test. It may be worsen the condition even to know it. And I think this is a collection of what Dr. Haytham said and what Dr. Safa said, because every patient different from, I can't make a rule for every patient, you know. You're treating a patient, not treating a role. Yeah, and I agree with you, Dr. Sam.
I have another point about pediatric, so Gammadex and the pediatrics. Personally, if I have a kid who is 7 years old or 8 years old and weighs 60 kilograms or 70 kilograms, like most of myopathic or myotonic patients, they have like body weight problem. I believe I can treat this kid as an adult based on body weight, not based on the age. What do you think?
Remember, the question for me?
Yes.
Okay. So, yeah, that's a very, very interesting question. Thank you so much, Dr. Osama, really. Well, I agree with you, but the main thing is it's all fatty infiltration, so there's no muscle power, by the way. So most of the muscles actually is a fatty infiltration, and that's what makes actually the Sugammadex, I mean, it's very interesting, actually having a resistant in the response. So at the end, whether to give the muscle relaxant or to give the reversal, you are judging about the response actually in a proper way by using the neuromuscular transmission monitoring of their TOF. And that's what makes them really think about when they apply the train of 4, they found actually those patients not really reversed simply, and they require even higher doses. But definitely, I agree with you, as long as you have a patient who has a huge body weight, actually that it actually gives you the potential to give a proper dose of 2 milligrams of Sugammadex per kg, 2 milligrams per kg of Sugammadex. Probably you should expect as well as you might really give another dose, higher doses as well, and the resistance will be high. Maybe this is what actually explains why we should prefer actually to give pediatrics a proper dose of Sugammadex. Yeah.
Okay, I got it. Thank you.
I think we have only last 2 questions, and they're related to each other. And I think Dr. Haytham touching these 2 questions. But one of our colleagues, I think Dr. Osama also, he's asking about do advise ICU booked routinely for all this patient, or and the second question related to it, what is the predictor for need postoperative ventilation for such patients?
You know what? I have. Let me start with the second question, because unfortunately, I skipped the slide of Leventhal score. I'm sorry for that, really, but I can bring it back anyway. So we have Leventhal score, and we have a couple of slides, and unfortunately, that being showed. But let me discuss it. Leventhal score actually is a very good way, to predict the postoperative ventilation. And Leventhal score, taking the concomitant lung disease and giving a points for each type, the vital capacity less than 0.3 liters, and moreover the dose of the hydrophonium or the biologistic mean or neustic mean, if it is more than 750, so you give 10 points, 12 points for the concomitant lung disease or the presence of COPD, and currently they add more as well the previous attack of myasthenic crisis as well. So all those criteria together in the form of the Leventhal score are currently, based on the last Cochrane review, that in case of you have a patient who had been admitted to the ICU before, so probably you should expect that, predict that those patients might really develop a postoperative ventilation problem and might really require an ICU. This is about the second part of the question. So the predictability mainly about the extent of the disease, the degree of the affection, the type of the muscles as well should be considered. If it's definitely the bulbar or respiratory muscle, that it requires actually that the postoperative ventilation should be impaired, and you should expect that at the end, along with the Leventhal score. What about the first part of the question?
That you routinely make a booking ICU bed for these people or not?
No. If, for instance, if you have a myopathic patient going for a breast surgery, make no point. Just to, as long as you're going to use the TIVA, I can run a propofol or remifentanil and not go to muscle relaxant, which is more convenient for you and for the surgeon as well. And the procedure takes around 2 or 3 hours maximum. So why you will keep the patient in the ITU? It's a cost at the end. And as long as if you are concerned about the muscle relaxant, you have the Sugammadex. The cost, let's say, if you have a problem with the cost and you are claiming that the Sugammadex is a very expensive drug, which is really an expensive drug compared to other drugs for used for the reversal as well, but the stay in the ICU is also very expensive. So this means actually that the patient have been reversed, and you have a document of reversal in the form of the train of 4 above 90%. So why would keep the patient in the ITU? Or you can keep him in the recovery for a little bit longer and make sure that the patient is fully reversed, and then you can send him to the ward. That's it. Yeah, but depends definitely on the type of the surgery.
Thank you, Dr. Sam. I think it is a time, Dr. Safa, but this is only one. Alaikum salam. It's okay. Dr. Sam.
دكتور صفاء دكتور هيثم السلام عليكم.
تفضل يا وسام. تفضل دكتور هيثم. This is Wissam Sultan. This is our colleague, our great colleague.
Our Sultan.
Wissam Eddin Sultan.
Nice to meet you. Nice to see.
Thank you, my professor. Thank you, Dr. Haytham, for your valuable and informative lecture. I have a comment and a few questions.
Yeah.
If you let me, thank you.
No, it's my pleasure.
Thank you. We know all that those patients are very sensitive to non-depolarizing muscle relaxant, and empirically we are giving 1/10 of the doses needed for them or needed for the regular patients. And as long as we are monitoring the patient, we have a neuromuscular monitoring, either quantitative or qualitative, and getting the right parameters for muscle relaxation, either deep relaxation or subclinical relaxation in some surgeons. So I think no worries or no fears, as long as we are monitoring the neuromuscular. Are you agree with me?
Can you come again, please, with the last part of the question, because I couldn't hear you really clearly.
Yeah. I mean that as long as we are monitoring, we have neuromuscular monitoring, either qualitative or quantitative. So no worries or no fears from using the non-depolarizing muscle relaxant by the minimum doses, which are giving us the response, the maximum response.
Yeah,
That's-
I'm trying. Yeah, I'm trying really to recap with you, Dr. Wissam, and you make a very valid point. Yeah, I mean, what I'm trying here to say, I'm trying to really to erase the fears from using the muscle relaxant whenever it be needed. I mean,
yes.
as long as you can manage to titrate your muscle relaxant in a way that it actually prevents any further consequences that might really affect the patient recovery or the patient safety, you can use it definitely. And trying to emphasize on the fact that the patient actually, myasthenic patient, for instance, could receive a muscle relaxant, a short-acting muscle relaxant safely without any problem.
Yes,
That's
what I'm saying.
With a myasthenic patient, if we have a problem with a myopathic patient, they could use a titratable at very limited doses of the muscle relaxant, and as long as you have a potential to give neostigmine or glycopyrrolate, for instance, or sugammadex, you can use it. And if you are
or both, or sometimes both, we can use both.
It could be used. You can use both. I mean, you can try initially with the neostigmine. If you found there is no response, and definitely if you have a trade of 4 qualitative or quantitative neuromuscular monitoring, you can manage actually to judge, or let me say, to consider really assessing the response. And if you have a very good response, probably it might really makes you more courageous. I mean, to send the patient back to the recovery, or even to monitor the patient even in the ITU as well for the residual muscle paralysis. That's the main thing. Yeah.
So yes, the other questions. You said that we have patients that might have delayed response to the sugammadex or rocuronium sugammadex reaction. In such patients, for how long this delay, and is it affecting the recovery or the quality of recovery? I mean, if the patient, I know that with sugammadex it takes almost 1 to 1.5 minutes to get recovered completely from the muscle relaxant. If this delay is 3 minutes or 4 minutes, or is it more than this affecting the quality of recovery?
Oh, that's such a absolutely a fantastic question. And you know, Dr. Wissam, usually, and my expectation, I mean, just for normal patient. By the way, when we talk about normal patient, doesn't mean that actually normal patient who is not having a neuromuscular disorder. But let's say we have a diabetic patient, for instance. Those patients have a neuropathy, and they might be associated with myopathy as well. There is what my expectation that plenty, let me say, like 15% of the patients walking in the streets, they have some sort of non-diagnosed or unknown type of myopathy. So the normal thing, I mean, the normal response for the sugammadex is the delay up to 3 minutes. Okay, when we talk about the delay, I mean, because the sugammadex as a drug, it actually takes up to 60 to 90 seconds to kick in. I mean, to give the particular response on the train of. But you should expect that those patients, you might really have a delayance, because as long as we expected that those patients will delay in the neuromuscular blocker, the effect of the sugammadex also will be the same. So there is a delayance. But when we talk about the delayance up to 5 or maybe 10 minutes, this is actually a significant delay. And that's what makes them emphasize on the need and recommend to send the neuromuscular transmission monitoring train of 4 even in the HDU, or I mean in the high dependency unit. In other words, if you need to send your patient to the ITU, no, send the train of 4 and allow the nurses, I mean the trained nurses, just to check the train of 4 after half an hour and see if there's response or not, to make sure that there is no residual paralysis. So even when even although that you are giving already the sugammadex, though this in the literature, I mean, there is no significant delay more than 5 or 10 minutes, according to my research. I mean, according to my search, there is the maximum delay was up to 5 minutes. No delay beyond that period, actually. Up till now.
Beyond this, yes.
They only discover anything.
Last question. I'm sorry for
take your time. No, take your time.
Thank you. I think this question needs a pharmacological background, because if we have patients with neuromuscular disease and in the same time he has chronic kidney disease or end-stage renal diseases, and as we know that the rocuronium is a great part or great portions of the rocuronium are excreted through the kidney or by the kidney or in urine, and also the complexes, the sodium-dex rocuronium complex are also excreted in urine. In those patients, do we expect that it might need or it might develop recuralization after a while, or another? The question by another, we can say that the complex is a rocuronium sodium-dex complex. For how long it lasts in the blood in the complex form?
Well, thank you for this kind of really very challenging question. Well, see, as I mentioned, the myopathy could be associated with other disorders or other comorbidities, diabetes, or maybe disorders, any metabolic disorders, or even kidney patients or chronic kidney failure patients as well. Okay. The main thing here is the extent of this comorbidity. I mean, when you deal with a controlled patient who's actually been controlled, I mean, the original disease is being is different. Is it different? You can hear me?
We hear you, Dr. Haytham. We hear you, Dr. Haytham.
Okay. When you deal with a controlled patient, is totally different than the non-controlled patient. Remember that we can use the sugammadex with the vicuronium as well. So, I mean, not only rocuronium, with the vicuronium, which is a little bit longer than the rocuronium. But most of us at the clinician prefer the combination of rocuronium with the sugammadex, because actually it's a handy combination compared to the vicuronium, which might last a little bit longer. Okay. And if the patient, for instance, having a kidney disease, definitely you should consider you'll be automatically, or let me say by default, passively, you'll reduce your doses, because as long as you're expecting that you reduce even the antibiotic doses or gentamicin, you will be also considered reducing the rocuronium doses and the sugammadex doses as well. And again, you will be controlling the responses based on your neuromuscular responses or the train of 4. And maybe you'll think about go back to other choice, like using the propofol remifentanil, because it's a little bit an ultra short acting. Am I right? You can go with the propofol remifentanil or maybe with dexmedetomidine. By the way, this combination is really a massively fantastic combination. You can use the propofol remifentanil, and it might really gives you, as long as you have a target controlled infusion and you're titrating the dose, it gives you the same and the most beautiful and the most aggressive muscle paralysis and a very beautiful surgical condition that it might really make your surgeon really bothering you with any further requests. So, I mean, this again, based on your clinical evaluation, based on your clinical assessment, you are in the field, you are on the ground, you are managing actually to choose whatever being safe for the patient. What I'm trying to do here is to put all the guns in front of you, and you can choose whatever the guns that will fires properly with you. I mean, if you think that your patient will get benefit from using the propofol remifentanil without affecting the kidney or the liver, you can go for it. If you think that the patient really normally can have the combination of muscle relaxant and sugammadex, you can go for it, as long as you know how to titrate and you have a neuromuscular transmission monitor.
Thank you, Dr. Haytham. Thank you.
Thank you.
You're welcome.
Thank you, Dr. Wissam. Thank you, Dr. Haytham. I think I want to raise the issue about using a muscle monitoring. This up till now, I'm just wonder, up till now, it's not an ASA standard monitoring. Even the report about 60-70% going to recovery, and I see that because I'm head of recovery, it's just still colorized, and I'm just wonder about this delay. Also, I think is coming in the horizon in the future a new muscle relaxant. It's called ganatricurium, and this ganatricurium can work very fast. like succinyl, 50 seconds or 40 seconds, and stay from 5 to 7 minutes. So it must give by infusion. And they have a very interesting metabolism. It's called cysteine adduction. So metabolized by acetylcysteine from the body. But even if you need just to reverse immediately, you can just give in acetylcysteine, which is variable. And I think it's coming very soon, because it will be added for our practice and our patient, and especially for patient with muscle relaxation. For me, we have in every machine neuromuscular monitoring. So whenever the case will go further, it will be long, I put the nerve simulator, and most of the time I don't give horrible amount what's written in the book to give every 45 minutes, every 30 minutes. Sometimes the patient very sensitive and give only one dose for 4 hours, 6 hours. Yeah. So we need just to give more and the patient more clearized and the patient not complain. So in conclusion, thank you, Dr. Haytham, and the lead now for Dr. Safa, and thank you for the speaker, presenter, and our colleague and our attendance, and lead for you, Dr. Safa. Thank you very much.
Dr. Safa, can I just say a few words? Thank you so much, actually, because from my perspective, actually, and that's what I believe, each time all of us, Dr. Yasser is a very good speaker as well, and Dr. Safa as well, I have no doubt with that. But I mean, I'm telling that to all our colleagues or all the audiences. Each time we present something, actually we learn from this, from the questions, we learn from the discussion, and we improve ourselves. So thank you so much for our colleagues as well, for their discussion, for their very fruitful discussion. So, and all of us, actually, it's a kind of, we reciprocate the learning, we exchange the experience, we exchange the mutual interpretation for our informations. Well, thank you so much.
Okay, it is time for me. Dr. Yasser, allow me, Dr. Haytham, last words. هيثم الجميل عازفا صائغا للآلئ. And this is, I will re-summarize some main points in your fascinating lecture. Really, it was an amazing one. So if we have a major abdominal surgery, and we in urgent need for muscle relaxant usage, or there is preoperative pulmonary disease, or obesity, or the patient have myasthenic crisis before. So this was our great professor, Dr. Haytham, to prepare or to book an ICU bed to do pulmonary function test, such as. Every time you can use total intravenous anesthesia in a type of surgeries that doesn't need proper muscle relaxation, eye surgery, bone surgery, etc., you can use the intravenous. This is towards the more safe for our this patient entity or type. Regional anesthesia, especially epidural, is recommended from our great prof, Dr. Haytham, to be used for as possible as we can. Total intravenous recommended, especially propofol and remifent. Of course, anytime we have immune system malfunction, we should suspect multi-system affection. Not only the muscle, not only the nerves, maybe the kidney, maybe the myocardium, etc. So أول ما نعرف إن في immune disease نتحسس رأسنا ونشوف باقي السيستم affected ولا لا. بشكر دكتور هيثم على هذا العزف المنفرد الجميل الرائع وصياغة اللآلئ العلمية الرائعة, very concise, very informative. محدش هينسى المحاضرة دي حضرتك يا دكتور هيثم, ومحطوطة بشكل رائع وجميل, وكتر خير حضرتك. مش هقول لك الا كده.
الله يخليك. تحت امرك. اتشرفت بحضرتك دكتور ياسر.
شكرا لحضرتك يا دكتور ياسر. شكرا لكل ضيوفنا الاعزاء الجمال. استاذ الدكتور أسامة بيه, اهلا وسهلا, نورت الدنيا. واعتقد ان الدكتور اشرف محي نديم موجود طبعا as a guest for the first time برضه. دكتور اشرف على راسنا من فوق, ومنور الدنيا كلها. دكتور اشرف كان الانستراكتور بتاعنا في الكورس بتاع الفاندمنتال كريتيكال كير سوسايتي، اعتقد ان هو موجود دكتور اشرف.
ايوه اهلا دكتوره صفاء. ثانك يو فيري ماتش.
منور الدنيا.
الله يخليكي تسلمي. يعني it's a pleasure و honor to be with you. يعني it's a great presentation. واحنا شغلنا اي سي يو اكتر يعني، ف بنشوفش الحالات دي كتير قوي، بس يعني يمكن الكومنت بتاعي السيديشن is very important. يعني titration السيديشن. So if it is the doses is high, the patient will eventually come to the ICU. But if he able to recover properly, it's more than important than the muscle relaxant. Yeah. Otherwise, يعني the complication will and the ICU admission and the consequence of all of this. But thank you very much. Yeah, it was a great presentation. Thank you.
Thank you so much.
شكرا جزيلا.
Thank you so much.
شكرا جزيلا. شكرا لحضرتك يا دكتور هيثم. شكرا. معلش
شكراً.
تعبنا حضرتك.
لا يا
تعبنا
فندم،
حضرتك.
اتشرفت. انا بعتذر ان في بعض السلايدز ما طلعتش في الحقيقه في السكيب، كانت بتبقى سكيب لان في ديلي في الواي فاي. I mean for no reason، انا مش عارف الحقيقه، بس يعني بعض السلايد من ضمنها الليفنتال سكور، هاو تو سكور. بس انا ام هابي ان انا ابعت لحضرتك الليكتشر تبقى كامله، تبقى مع حضرتك، على اساس لو حب اي حد يستفيد بيها تبقى موجوده مع حضرتك، وانا بقى سعيد جدا.
دكتور هيثم، انا معايا ناس في نقابه الاطباء بيحضروا، لان انا باجي احضر الزوم في نقابه الاطباء عشان يبقى فورمال، فهم بيقولوا لحضرتك هم كمان هيبقوا فيري هابي لو حضرتك بعت البرزنتيشن.
ده with all of my pleasure really. ده يعني with all pleasure. With extreme pleasure.
Thank you.
I was honored to be with you and with Dr. Yasser and with all of the very really honored colleagues, respected colleagues. I'm so happy, very delighted to be with you, and thank you so much for your help and for attending my lecture. Thank you so much.
احنا هنقول لحضرتك ربنا يكبر خاطرك يا دكتور هيثم. ربنا يكبر خاطرك. ربنا يكبر خاطر حضرتك يا دكتور ياسر. شكرا تعبت حضرتك معايا.
شكرا. هو طلع جميل فعلا، هو طلع جميل يعني.
يا باشا انت عينك الجميله.
بص من فضل حضرتك المره الجايه مش هتمنعني ان اقول اللي انا عايزه اقوله، بس خلاص.
بس تجيبي دكتور